So I just wanted to color a couple other studies that were not randomized controlled trials that kind of continue to show the controversy and the inability of a lot of evidence to tell us whether there's real usefulness to SMBG or not. The ROSSO study looked at the relationship of SMBG with disease-related morbidity and mortality. The study followed 3,000 patients roughly with the diagnosis of type 2 diabetes between 1995 and 1999 until the end of 2003. So they had a mean follow-up of about 6.5 years. And this was actually a retrospective review from medical records. And so what they found, they were looking at endpoints, all-cause mortality, blindness, dialysis, MI, stroke, and amputation. And that was their endpoint. You'll see that the red lines are actually the SMBG cohort, the blue lines the non-SMBG cohort. You'll notice that the SMBG cohort started at a much higher A1C and fasting blood glucose than the non-SMBG cohort. And what they saw was that the SMBG was associated with a decreased related severe morbidity and all-cause mortality, and that both groups initially had some effect and were able to maintain that with the use of self-monitoring of blood glucose. These are the survival curves, which again showed that the red is the self-monitoring group, the blue, the non-self-monitoring group. And again, this study did show that they had decreased related morbidity and all-cause mortality by folks that utilized self-monitoring. The Fremantle study assessed whether SMBG was an independent predictor of improved outcomes in a community-based cohort. This was a cross-sectional design, and it actually also looked at folks on diets alone, oral medicines, and then multiple insulin injections. And they actually saw that SMBG was related with a 48% decreased risk of cardiovascular mortality in insulin-treated diabetics. But they found an actual 79% increased risk in non-insulin treated diabetes. So what they found was that, again, very useful for folks that were treated with insulin, but actually found increased risk of the use of SMBG with those that were non-insulin treated. And then they did found that it was actually SMBG was independently associated with a 48% reduced risk of retinopathy in the entire cohort. And this study just shows, again, it's a little bit difficult to read because they're kind of right next to each other. And it's mainly looking at the A1C impact of blood, of whether you're monitoring or not monitoring. And you can see that you know, they're relatively, and these were not statistically different in most of these cases for folks that monitored or not monitored with regard to the hemoglobin A1C benefit. So the DIGEM study looked at 3 arms, and it was determined whether SMBG alone or with instruction in incorporating results into self-care would be more effective than standardized usual care in people who were non-insulin treated. They followed 453 non-insulin treated type 2 diabetics with the average A1C initially at start at 7.5. And what they saw was that there was no statistical difference at 12 months in the A1C levels. So again, DIGEM looked at non-insulin treated folks over time, randomizing them to more intense versus less intense versus normal care. And what they found was that there was no improvement in hemoglobin A1C. What they did found was that in both groups, but certainly greater in the more intensive blood glucose, was that there was minimal, the adherence waned over time. So again, when you're asking people to prick themselves and check their blood sugars multiple times a day, many of our patients, you know, perceive that as interrupting their quality of life or really get tired of doing it, and so their compliance with it wanes over time. This I just wanted to kind of put in here. This was a study that was done looking at meal-related structured self-monitoring of blood glucose. And this was a randomized controlled trial that basically compared an education intervention combined with monitoring. And what I wanted to show there is that there was improvement actually with the intervention tied to, with blood glucose tied to an intervention, that being this lower curve versus regular or no testing. And I think that that will become clear and more important as we kind of talk about, well, what is the utility of testing? Again, going back to insulin-treated patients, as they're testing for a purpose. They're looking to do something with those results. They're not just sort of gathering data that may or may not be reviewed by someone. One last study, again, this looked at a huge registry of Kaiser patients, looked at for strip use, and basically this actually also showed that for those folks that had that tested on a more regular basis, that there was improvement in hemoglobin A1C. Throw in one last trial, which was the Esmond trial, and the reason why we put this in was to talk about, basically this looked at the impact on psychological indices in patients with newly diagnosed type 2 diabetes who were asked to monitor or not monitor with self-monitoring of blood glucose. They evaluated 184 non-insulin treated patients who had no prior experience with monitoring. And what they actually found, that they found no difference in the hemoglobin A1C between the groups over the 12-month period. And they also noted that the group that was required or asked to do self-monitoring had a 6% higher score on the depression subscale of the well-being questionnaire. So again, the Cochrane review said that, you know, in their 12 trials, randomized controlled trials, they didn't really find that it impacted the well-being or not. I suspect all of us have had instances and conversations with our patients who say, you know, it kind of bums me out to have to check my blood sugar multiple times a day. Or I've had patients tell me, you know, it's just a constant reminder and I don't know what to do with the information, or I'm not sure why I'm doing it, so I just choose not to do it. And then lastly, we need to talk cost. Now these are some old numbers. I was unable to come up with some new numbers, but the cost of monitoring is huge. You know, it is estimated that, you know, and this was 10 years ago, $6 billion is spent worldwide on monitoring. When you think about the monitoring and the components and the strips and everything, it's a huge money business, and it costs our facilities and limited resources a lot of money. When I was preparing for the talk, I was talking to some of the pharmacists at the Phoenix Indian Medical Center, and they shared with me something that I had not heard, which was evidently strips are a big hot ticket item at the flea markets. And so there are patients who are taking their strips and selling them at flea markets because they can get $20 a bottle or $30 a bottle for the strips. So we need to make sure that if we're dispensing these, again, it's for a medical device and that we're doing it appropriately and that we're utilizing the limited resources that we have and are doing it in an evidence-based way. So in summary of the research part, you know, there's conflicting data to support the benefit of standardized, and I'll say standardized because it's going to be another key point, self-monitoring for people who are not insulin treated. The most recent review really has shown that if you're going to do it and do it intensively, doing it in newly diagnosed patients during the first 6 months, certainly up to the first year, is going to get your biggest bang for your buck. And even in folks who have been diagnosed for longer than a year, probably you're not going to get necessarily a lot of benefit in glycemic control by intensive monitoring after about 6 months. You know, there's so much controversy. I tried to choose some studies that showed, yes, it is beneficial, no, it's not beneficial. And I think that what you'll find is the clinical guidelines are saying we still need more data. We still need more randomized controlled trials to determine the best way to do this and how we're going to get the best results and be able to take care of the best we can for our patients. And then lastly, it's really an expensive prospect. You know, the Phoenix Indian Medical Center spends about $350,000 a year on strips. And that's a substantial portion of their pharmaceutical budget, as well as I'm sure each one of your facilities is spending as well.